Alright guys, in this video I hope to finish up with the gallbladder and some of the diseases that are caused in the gallbladder. We went over in the last video over cholelithiasis, cholelithiasis, which are basically stones, one in the gallbladder, the other in the biliary tree, and how to use the HIDA scan and the MRCP to determine treatment. Always ultrasound being always the first choice. In this video, I'm going to discuss cholangitis, also known as ascending cholangitis, and we're going to talk about cholecystitis. Okay, we discussed the varicose triad, which doesn't necessarily always have to be present, but the nausea, vomiting, fever, pain, jaundice, those are all signs and symptoms that you could put together for saying, listen, there's a biliary disease going on. It can be cancer, cholangiocarcinoma, adenocarcinoma of the gallbladder. The cancer itself can be the obstructee, can be the pathology itself. The swelling can obstruct this. It could be a stone, like we talk about the lithiasis, and they could be present in different areas. Okay, and the treatments obviously for a stone will be an ERCP, and if there's no blockage, then the treatment will be a surgery. The ERCPs can also be used in the case that there's no stone. ERCPs can be deployed. They go through the, obviously, endoscopy into the stomach, pyloric sphincter, and they go in through the sphincter of Oddi. The sphincter of Oddi, you're going to see two ducts. You're going to see Werson's duct, which is the main pancreatic duct, and they're going to see the common bile duct uniting. And they go up the common bile duct, hopefully, and they pick the right duct. And depending on, I think they could go up as far as the right and left biliary tree. So you can imagine how small these the endoscopy stents are, because it keeps on deploying a smaller and smaller tube as they go along. And they do have a camera at the end of them, so they do see where they're going. So the farther up that they go, the more difficult it obviously becomes to do things, but they can deploy a stent. So say that there's a stricture right over here in the common bile duct, but they can come up here with endoscopy, and if they see and visualize no stone at all, what they do is that they deploy a stent. Okay, they could deploy either a metal stent or a plastic stent. Okay, the metal stents are hard to remove, so they're more permanent, and plastic stents are removable. Okay. They both have their benefits and their flaws. If it's a cancer and you put a metal stent from the very beginning, cancer can grow above this stent and start causing a stricture over here. And since you put a metal stent, you may not be able to remove the metal stent. So what happens is that now it's harder to get to that area over here, and you cannot stent this area. So now this patient's bilirubin will go through the roof up to 40, 50, 60, whatever it has to go to. And the patient will have a more uncomfortable progression of the disease. So the plastic stents do have a good role. Metal stents do have their place as well, but this is just a small example of the differences between them. The next thing we're going to talk about now is the actual cholecystitis. Okay, cholecystitis is inflammation of the gallbladder. All right. It is usually caused by gallstones themselves, but sometimes are not necessarily caused by gallstones themselves. And the way you diagnose this is with ultrasound. In the ultrasound, they usually, I believe the number is 10 millimeters in thickness with surrounding fluid, and that basically indicates an inflammatory process of the wall. I believe that the wall of the gallbladder shouldn't be much more than maybe 3 millimeters or 4 millimeters, so 10 millimeters is pretty significant to diagnose a gallbladder inflammation. The treatment for cholecystitis is actually antibiotics. Okay, treatment for antibiotics. Very typical treatment will be the combination of ceftriaxone and metronidazole or flagyl. And depending on if they find stones or not, or depending on how diseased the gallbladder seems, they will obviously schedule you for surgery to take this out. But depending on how severe you are, they may take you in right away, or they may deem, you know what, this individual seems to be getting a little bit better with antibiotic treatment and IV fluid, so let's just hold off a little bit, and you might be able to go and get it electively done. If you have stones in it, it obviously makes things worse, and you may be in a more of an acute necessity for resection right away, a cholecystectomy. Cholangitis is going to be the last thing we're going to talk about, and basically cholangitis, the treatment for it is also you don't reject the bile ducts. I'm sorry, not reject, but you don't resect the bile ducts, because for some reason, and if somebody can find an answer and just post it or reply to me, I haven't found a surgeon to tell me that they have stents to replace this. I mean, we have cardiac stents, we have stents that we deploy inside the gallbladder. We could do a venous graft and harvest a vein anywhere else in our body to put it as a coronary bypass surgery, but I've never heard of biliary bypass. I've never heard of a stent that you could, if you have cholangiocarcinoma over here, I've never heard of you being able to resect this, take it out, and have an anastomosis. All right. I'm not too sure why not. I mean, I would believe that we have the technology to do so, but it's just not an option right now. So if anyone ever hears of something like that, please go ahead and inform me, because it would be a great thing. A lot of patients can be saved, and cholangiocarcinoma and gallbladder cancer is a very bad disease. In cholangitis, what happens is that you have inflammation of the bile ducts, whether it's up in the left and right hepatic duct, or the cystic duct, or the common bile duct. What happens is that usually whenever you have an obstruction, whether it be because of a tumor, malignancy, or because of an actual gallstone, you have more stasis and inflammation of this area. By having more stasis and inflammation of this area, you're not draining fluid as you normally should be. So you're not moving things. It stays stagnant. Now, the small intestines, the small GI, duodenum, jejunum, and ileum, shouldn't normally have bacteria in them. But remember, they're connected to the colon. Bacteria can very easily ascend and enter the biliary system. The thing is that when you have biliary disease, you tend to not have an appetite. All right, you tend to not have motility as much as you do when you're eating. So bacteria can accumulate, and bacteria can crawl up, and you also have transient bacteria. Remember, you're full of lymphatics and full of capillaries all over the gastrointestinal system. So there are occasional bacteria that travel, whether it be through your blood, and yes, you can have bacteria in your blood, transient bacteremia, that won't trigger a fever and that won't necessarily cause a disease. It won't cause you to feel ill. Your immune system will take care of it. So transient bacteria do travel through your body all the time. You could end up with an infection of your foot or an infection of your knee because of bacteria that travels from the gastrointestinal system to a certain area. It's very, very uncommon, but they do exist, and I've actually seen patients where they had bacteria from their colon on their foot. How do you explain that? You know, so bacteria does tend to travel, and if you have stasis and not normal, and you don't have your normal movement of contents through this area, you're more prone to getting an infection. All right, so bacteria, usually E. coli is the main one that is found in the cholangitis. Okay, how do you treat this? The main treatment, once again, as I mentioned before, very popular drug to use would be the combination of ceftriaxone for gram-negatives and a metronidazole or flagyl, the same drug. They are both available IV. If you want to go with the oral form, you usually go with Levaquin, which will also cover your gram-negatives, and metronidazole or flagyl are also available PO. Okay, ceftriaxone is only available IV. And this should actually get your patient feeling a lot better within a couple of hours. So that's a treatment for cholangitis and cholecystitis. I wanted to mention the chances of you getting pancreatitis from an actual gallstone. And I also wanted to mention a myth or a conception that they had on pain management. Since I only have about 2 minutes left, I'm going to try to cover this as fast as I can. Normally in pain management for right upper quadrant pain, it was said that morphine can cause a sphincter of Oddi to not relax, to spasm, and not only cause more pain, but basically block any drainage that could be there, and it was thought, oh, that's not good because the enzymes from the pancreas can build up and cause pancreatitis. Well, that is not true. If you look at studies that have been done, morphine and other opioids via the mu receptor do block do overpower the acetylcholine, and they do reduce GI motility. Okay, so no, it is not true that opioids should be avoided in right upper quadrant pain. They're actually very, very good. They're actually better than Demerol, not only in pain management, but in reducing seizure thresholds. So if you're thinking of giving Demerol because you're scared of an opioid to cause sphincter of Oddi stricture and causing damage, think twice. It's not true. It has not been proven. Okay, it has not been proven that opioids cause constriction of the sphincter of Oddi and increase the pain and can increase the symptoms of the patient. Okay, and it doesn't decrease the threshold for seizures like Demerol does. Okay, Demerol is a very good drug and it's also been used for this, but it does decrease the seizure threshold as well, and it's not going to be as powerful as an opioid like Dilaudid or like morphine can be.